advanced gynecological reproductive surgery. So things like keyhole surgery for conditions like endometriosis and fibroids, which I will touch on later. So thank you for taking the time to spend this morning with us. Charles has asked me to speak on a broad range of subjects in the context of our new COVID reality. So I thought we'll start by just touching on COVID generally, and then talking about fertility services, especially as it impacts the Afro-Caribbean community, gynecological services, especially as they impact the Afro-Caribbean community, and what the reality is for those services now in our COVID world. And then we'll end with, we'll leave plenty of time for discussions and questions. And as Charles said, if there are more private or confidential things that people want to discuss with me, I'm happy for Charles to link you up with me, and we can you can either direct message me or we can have private conversations outside of this forum. So I think there's been plenty of publicity about COVID, so we all know what's going on. And what I'd just like to say is that it's a very, very serious infection. It's nothing. It's not a joke at all, and so we should give it all of our attention and take it very, very seriously. Particularly since we, as the Afro-Caribbean community, appear to experience the more severe end of the complications we get from COVID. What the evidence suggests, as you know, this is a new infection. Last year, nobody knew what coronavirus 19 was. It is a new infection, and we're just finding out things as we go along. But what we know so far indicates that it's one of the most virulent infections humanity has experienced so far, meaning it's very easy for you to catch it. And although when you do catch it, it can be a very mild infection in the vast majority of cases. Probably 80% of people will have no symptoms at all, or very mild symptoms. But the 20% of people who develop symptoms, what we're finding is that the Black community has a disproportionate representation in those who develop more severe complications. And so you find that the rate of admission to intensive care and the rate of, sadly, fatalities is skewed negatively towards people of Black and Afro-Caribbean origin. So it's really important for us to take this infection seriously and to do everything we can to protect ourselves and our families. And I always like to tell people that when you're thinking about COVID, do not just think about yourself. Even if you feel that you are at minimal risk of the infection, think about everybody who you contact. So think about your family, think about your children, think about your spouse, think about your parents, because if you could have the infection and be completely asymptomatic, but you'll be able to transmit it to other people. So we need to take responsibility for everyone we make contact with. So we all know about COVID. We all know about the general advice. I think that holds, especially for us. Advice about keeping ourselves safe, about social distancing, both at work and at home. It's really important to stress this because the only thing we as individuals can do to combat the serious consequences of this infection is to avoid getting it. Once you get it, you're effectively at the mercy of the infection. We don't know the characteristics of people who have more severe complications from it in terms of their biological makeup, apart from the fact that we know that it's more prevalent. It's more likely to cause more severe disease in people of Afro-Caribbean origin. So maintaining social distancing is really important. And just trying to keep ourselves safe, really, really important. And when you're at work, I think you need to think about, we all need to think about the way we conduct ourselves. So things that we're familiar with and used to take as normal, we need to rethink. Things like using workstations, using communal kitchens, restrooms, meeting rooms, stairs and lifts. We all need to take particular precautions to try and minimize our risk of catching COVID from those environments. So the government advice is for us to stay alert, try and keep ourselves and our families safe, and avail ourselves of testing. So anybody who feels they've developed symptoms of any kind, you can just ring up the NHS testing site now and drive to your nearest testing center. And I think that's really, really important. The last thing I'll mention about COVID is to encourage people of Afro-Caribbean origin to avail themselves of vitamin D. There's still plenty of work going on, but the little bit we know so far indicates that vitamin D is very helpful in, first of all, reducing the risk of catching COVID, and secondly, in minimizing the risk of getting very severe consequences of COVID. So I would encourage everybody of Afro-Caribbean origin to be on vitamin D supplements. Because of our darker skin tone, it's more difficult for us to get vitamin D from the little amounts of sunlight available in the United Kingdom. That's why it's really important that we help ourselves with vitamin D supplements. And indeed, I would encourage all of us to also be on other multivitamin supplements. So I will stop there for COVID for now, but obviously when we come to the question and answer sessions, I'll be happy to address any questions there. So what I'll do is I will touch on fertility services and then gynecology services. There are peculiarities within the Afro-Caribbean community when it comes to fertility issues. We, as a community, appear to have I wouldn't say a greater burden of fertility issues, but I don't know if it's peculiarities within the Afro-Caribbean community. We tend to carry a higher burden of the consequences of fertility issues, and I'll explain what I mean. One of the things that has really troubled me over the last few years is whenever I find a woman of Afro-Caribbean origin walk into my fertility clinic over the age of 35, I really worry about her ovarian reserve, meaning the number of eggs she has left in her ovaries. Because what I have found over the years is that compared to our Caucasian counterparts, women of Afro-Caribbean origin over the age of 35 seem to have significantly reduced ovarian reserve. And that is reflecting in what we find from our fertility treatment services. So if you take comparable couples of Afro-Caribbean origin and Caucasian origin with exactly the same biological characteristics and apply the same treatment protocols to them, what we're finding is that the couples of Afro-Caribbean origin have a 30% reduced risk of having successful treatment, fertility treatment. We cannot understand why that is, but that's what we're finding. And we're beginning to look at ways in which we can help people from our community to try and close that gap. But there are many things that we can do within that community to help ourselves. And that's why I hope that forums like this will help to spread the message. I think knowledge is power, and the more people who know how their bodies function and how they can optimize their bodily functions will be able to help themselves better. When it comes to fertility, there are three key triads of fertility. So there is the male sperm, producing sperm. So a man has to have healthy sperm and be able to produce those healthy sperm. And the general health of a man impacts significantly on the health of the sperm he's able to produce. And what a man takes into his body in terms of food, drink, drugs, alcohol, all those things impact significantly on the quality of his sperm. So the message to men is keep healthy, eat healthily, avoid use of medication and social drugs. The other pieces of the triad are the eggs that a woman produces. So a woman needs to have enough eggs in her body and be able to produce those eggs on a regular basis through the process we call ovulation. And the egg and the sperm need to be able to come together within the body of the woman to meet, for the sperm to fertilize the egg and to lead to pregnancy. And that's where the passage is important. So the woman's fallopian tubes, her uterine environment have to be healthy to allow that to happen. Within the Black and African and Caribbean community, one of the things we do find, as I mentioned, is for some biological reason, women appear to be very fertile at an earlier age compared to their Caucasian counterparts. And it appears that during those periods, our women are recruiting and using up a lot of their egg pools within their ovaries. And what that unfortunately means is that as they come to older ages, over the age of 35, that egg pool is significantly reduced, and that starts to impact on their fertility. Because women do not produce any new eggs in life. All the eggs women have are eggs that have been deposited in their bodies when they were little babies growing in their mother's wombs, and women deplete those eggs all through life. So it's really, really important for women from this community to know that. And I always encourage women to consider having a simple blood test called the anti-Mullerian hormone. And this is a really reliable test that gives us an indication of a woman's egg pool. And that test can be taken at any stage in life over the age of 25, and is a very reliable indicator of the egg pool of a woman, and that can help women to make informed decisions as to how to plan their fertility journey. There are things that can affect, as I said, the passage between the egg and the passage where the egg and the sperm need to travel to meet. There are things that can affect that. So there are conditions that can affect women, including endometriosis and fibroids, which I will touch on in the next section, that can distort that passage and that can cause problems. But those are conditions that are very, very easy for us to diagnose. So my advice always is that people seek help at an early stage where these things can be picked up very early, and there are things that we can do to help to correct them, to help our women. So when it comes to fertility, there are very, very simple tests we can do to assess the fertility of both males and females. And once we understand what's happening with that, then we can apply appropriate treatments to help them. And one of those treatments we apply is IVF treatment, which is where we stimulate the woman to produce more eggs, collect the eggs, collect sperm from the husband, mix them together in the lab to generate what we call embryos, and then transfer those embryos back into the woman. And over the years, I've been involved in this field now for well over 20 years. And over the years, the success of IVF has increased very, very significantly, to the point now where with IVF treatment, we're almost able to double the natural monthly fertility rate of a couple. The key to IVF treatment is the most significant factor that impacts the chance of success of IVF is the egg pool of a woman. And unfortunately, if that egg pool is depleted to the point where we do not have eggs anymore, then the only thing we can do to help a couple in that situation is to get eggs from another female. And that's the process we refer to as egg donation. egg donation has become a really important way of helping couples to achieve their desire of pregnancy and live birth. And I can tell you now that in the UK, about 2% of all babies that are born every year are delivered following egg donation. And it is a very successful and effective way of helping women in that situation when we otherwise would have no other way to assist. The difficulty we have with egg donation in the African Caribbean community is we struggle to find Black egg donors in the UK. We don't know why that is, because we do not find the same issues with other Black communities around the world. So in places like the United States, in African countries like Nigeria, where I come from, in other European countries like Spain, they do not have the same difficulties and they can easily find Black egg donors. But we struggle here in the UK. I have couples that have been on my database for well over 5 years waiting for Black egg donors, and we just struggle to find them. So the message I'm putting out there is there is a real desperate need to find Black women who can donate eggs in the UK. Any female who's healthy, who's under the age of 35 years, can potentially donate her eggs. And if there's anybody like that who's thinking about it, I will be very happy to have a private discussion with you to give you more information. So how has COVID impacted on fertility services? The UK government shut down all fertility services sometime in March this year to free up space for the response to COVID. And so unfortunately, women who were on the journey or waiting to start their fertility treatment, we had to put all that on hold. Fortunately, now that we've moved on to a less acute stage in our response to COVID, fertility services have been opened up again. So we're just in the process of writing to all women who are due to have fertility services to recommend the pathway for them. So we're hoping that from maybe the second half of June, we'll be able to start with IVF treatment services again. So what I would encourage anybody to do who's on that journey, who's had their treatment put on hold, is to recontact their clinics to discuss how to recommend services. And again, I'll be happy to take questions on this later on. So I'll just touch very briefly on 2 gynecology services. And again, I'll start with the impact of COVID on those services. Similar to fertility services, all elective gynae services were stopped by the UK government again in March. So we've not had any face-to-face clinics, we've not had any elective surgery. So all that has been put on hold. But the expectation is that from July, we'll be able to recommend those services. But there will be a huge backlog, as we appreciate, and it might be slow for things to get moving again. The two conditions I'm just going to focus on are fibroids and endometriosis, and that's because those conditions have particular bearing on the Afro-Caribbean community. Fibroids are very common, but they're even more common in women of Afro-Caribbean origin. And what fibroids are, they're essentially benign tumors of the womb, and they affect up to 50% of women of Afro-Caribbean origin. And they can cause all sorts of problems from pain and heavy bleeding to swollen abdomen if the fibroids get really big, and to fertility problems if they get big enough and many enough to distort the cavity of the womb. As I said, they are very common in the Afro-Caribbean community. There are actually some studies that suggest that above the age of 40, fibroids are found in 75% of Afro-Caribbean women. So they are really significant, but they're very simple ways of diagnosing fibroids, and we have very effective ways of treating them. usually by surgery, and it could be by keyhole surgery, where we put a camera through the neck of the womb into the womb to remove fibroids, or keyhole surgery, where we put a camera through the belly button into the pelvis to remove fibroids, or if they're too big for any of the two measures, by open surgery. But they're very effective ways. And the treatment of fibroids will generally result in improvement in the woman's quality of life and would aid fertility. So for any woman who's suspecting they have fibroids, if they have heavy periods, very painful periods, abdominal swelling, they should see their doctor and see if they do have fibroids. I'll just touch very briefly on endometriosis. Endometriosis affects about 10% of women. It's not more common in the Afro-Caribbean community, but the impact of endometriosis can be really profound. It causes pelvic pain, especially cyclical pelvic pain that appears to recur irregularly just before and during menstrual periods. And for some women, that pain can be so severe that is completely debilitating and disruptive of their normal routines. The one thing we always say is that, yes, we understand that women can have painful and heavy periods, and sometimes that can be not due to any underlying cause. But if any woman is experiencing regular monthly pain with her periods that stops her working, stops her fulfilling her normal functions in life, looking after her family, then that is not normal. And it's very likely that a woman like that would have something like endometriosis, and I would encourage them to seek medical help, because there are different stages of severity of endometriosis, and the earlier we diagnose it and start to treat it, the better the outcome for the woman. And with endometriosis, there are very, very effective treatments. Again, we do keyhole surgery to excise endometriosis. So that's what we call laparoscopic surgery, where we put a camera through the belly button and remove the lesions. And as I said, those are things that are available, and people should avail themselves of those services. So I would round up on this general discussion for now, because I know I've seen people put through a number of questions, and we can start to address those questions. But just to say that anybody who is experiencing difficulties because of the disruption in services, I would like to reassure them that we're beginning to put those services back in place now, and they should contact their medical team to find out when things will be able to restart for them. Whilst they're waiting, there are ways they can help themselves. There are plenty of websites available that they can get information on how to manage symptoms whilst they're waiting. And as I said, I'll be more than happy to engage with people if they want to have private chats with me to see how we can help. I'm going to stop there for now, and I would be happy to take questions.
Okay, thanks, Doc. So a number of questions, some have come privately, some in the chat. So the first one is, do you think it will be difficult re-embedding the importance of smears message once the pandemic eases, given that none has been done now? Women of African Caribbean descent likely to be going, likely to be more detrimentally affected by smears being stopped, in terms of the fact that we are higher, of higher risk of gynecological, cancers.
Absolutely. I would second that. All services are going to be reestablished. What we're going to do, which everyone would appreciate, is that we're going to prioritize services, and smear services are one of those services that are going to be prioritized. Despite the fact that we're going to be able to start reopening gynecological services from July, we're still going to have to maintain all the responsible risk minimizing measures So we're still going to have to enforce social distancing in our clinics. We're still going to be able to limit the numbers of people who come in. So it's not going to be business as usual. A lot of the consultations we're going to do now are virtual consultations. So similar to what we're doing now, rather than all of us gathering in a room, we're doing this and we're still getting effective information by doing this. And that's how we're going to start to do our consultations. So things like women waiting for cervical smear tests, they're going to be prioritized. And I would encourage anybody whose smear is due to start making contacts with their GPs now and to start finding out when they can be scheduled to come in to have them done. I'll reassure women that delaying your smear test for maybe about 3 to 6 months is not going to significantly impact you. So I don't want women to be worried that their conditions are going to worsen significantly. But what I wouldn't want them to do is to forget about going to update their smears just because of the COVID pandemic.
Thanks, Doc. The other question is, why are Black women more likely to get fibroids? And what early prevention guidance can be given for our women to avoid getting fibroid?
That's a really good question. I think there is still space in the Hall of Fame for anybody who discovers why the cause of fibroids. The simple answer is that we don't know. We think that there is a genetic predisposition, and we think that that genetic predisposition makes Black women more likely to develop fibroids. I'm sorry, I think the second part of the question was, what can they do to prevent?
Yes.
Yeah, because we don't know what causes fibroids in the first place, unfortunately, there is nothing you can do to stop you getting fibroids. What we generally say is that any woman who lives long enough, it's likely to develop fibroids at some stage in life. The good thing is that the vast majority of women do not have any problems from fibroids. They remain completely asymptomatic. They don't disturb them in terms of their periods, just going about their normal life. That's the good thing. But unfortunately, we cannot stop women who are genetically predisposed from developing fibroids.
And Doc, why is that some of our women have surgery, but then the fibroids grow back?
That's a good question. I think the simple answer is that we cannot stop fibroids from developing. For anybody who's genetically predisposed, we can stop fibroids from developing. What we can do when we treat women is we can remove the fibroids we find at any point in time we treat them. But if I remove your fibroids today and you're genetically predisposed to developing fibroids, nothing stops you from starting developing new ones from next year. So because of that, women can have a recurrence of fibroids. The one thing we do know is that the older you are at the time you have your fibroids treated, the less the risk of you developing a recurrence. But fibroids are what we call estrogen-dependent tumors. So meaning any woman whose ovaries are still working, who's still going through a normal menstrual cycle, and who is genetically predisposed to developing fibroids can develop that fibroids at any stage, irrespective of if they have their fibroids removed at any time. As long as they still have ovaries that are functioning, producing estrogens, then fibroids can regrow at any stage, unfortunately.
And Doc, another one, how does that affect pregnancy or conception?
That's a really good question. Fibroids can impact both pregnancy, so the ability of a woman to get pregnant, and also the ability of that pregnancy to carry on to lead to live birth. So the way fibroids impact pregnancy is one to do with their size. The average width of the womb is maybe about 4 centimeters, while the length is maybe about 7 centimeters. So you can imagine that if a womb is harboring fibroids that are larger than 5, 6, 7, 8 centimeters, and we find this sometimes, the largest fibroid I have removed from somebody's womb was about 25 centimeters in diameter. So you can imagine that a womb that is harboring a fibroid like that is going to be completely distorted by that fibroid. Now, any fibroid that distorts the lining of the womb, meaning the inner layer of the womb where a pregnancy implants and grows, any fibroid that distorts that has a significant chance of impacting the ability to get pregnant. And even if pregnancy happens, significantly increases the risk of that pregnancy not carrying on, meaning a miscarriage happening. So it's mostly a mechanical effect because of the presence of a fibroid close to or within the cavity of the womb. And that's why it's really important for women who have maybe a delay in getting pregnant or who have repeated miscarriages to seek medical help. Because one of the things we do if we find fibroids in that position is to remove the fibroids, and that has a significant, that leads to a significant improvement on their chances of conceiving and being able to carry the pregnancy to term to life birth.
Thanks, Doc. More questions coming. What is the test for egg-proof called? And also, can women over the age of 40 donate eggs, and will that be healthy?
That's really good questions. Now, the test for your egg reserve is called the anti-Mullerian hormone. It's AMH for short. Anybody who wants to have that test, if you Google AMH, A for Alpha, M for Mother, H for Hillary, you'll be able to get information on it. And the test is offered by all private clinics. It's unfortunately not available through your GP because it's quite a specialized test. But my recommendation is that every woman over the age of 25 just needs to get that test at some point. So yes, I'll encourage you to find out a bit more about it. Now, regarding egg donation, every country has different ways of regulating egg donation. The United Kingdom is probably the most regulated country when it comes to fertility issues, and egg donation is of particular relevance. We have a body here called the HFEA, the Human Fertilization and Embryology Authority, and we have to register every fertility patient with them, including egg donors. And they are governed by the Human Fertility and Embryology Act in the UK. And that act states that to be able to donate your eggs in the UK, you have to be under the age of 36. So any woman who's over 35, if they're planning to donate eggs, they have to donate it before their 36th birthday. After your 36th birthday, we unfortunately cannot use you as an egg donor. And there is a rationale for that law. What the UK government wants to ensure is that when you use an egg donor, you want to give the recipients the chance of having the best outcome from that treatment procedure. And to get the best outcome with IVF, the more good quality eggs you have, the better your chance of getting an outcome. So as I mentioned earlier, as women get older, especially past the age of 35, the numbers and the quality of eggs they have decline quite significantly. And so that law is to ensure that we're using much younger women where the chance of getting many good quality eggs is available to the recipients. So unfortunately, we cannot use a female at the age of 40. Now, every law has a little leeway, and in the UK, the leeway we are allowed is that if a woman comes to me, for instance, and the only person who can donate eggs for her is her sister, and her sister is over the age of 35, I can investigate her sister to find out what her ovarian reserve is. And if I can demonstrate that the sister has adequate ovarian reserve, even for her age over the age of 35, I can apply directly to the HFEA to get an exemption for me to use her sister as her egg donor. So those are the sort of leeways that we've got.
Thanks, Doc. Right. So as a fitness coach, I have read an American, study article that young women who train using compound weights can go into early menopause as their period hormonal slows down. Is that true?
Sorry, Charles, just go through that again. I don't think I got all of that. You said young women who
Train,
excessively?
no, athletic, young
Oh, yeah.
women who train using compound weights, they can have early menopause. Is that true?
In the strict sense, it is not true, but there is an iota of truth in that statement. So what happens is nature has designed a woman's menstrual cycle. If we start from the beginning, the whole purpose of the menstrual cycle is to prepare women for reproduction. So when a woman goes through the cycle, what is driving the cycle is that she's releasing an egg from her ovary. And because she's releasing an egg from an ovary, the lining of the womb is getting prepared for pregnancy. If that egg doesn't get fertilized and implant into the lining of the womb for pregnancy to occur, she sheds the lining of the womb, and that's why a period recurs. And that recurs every month. So effectively, the whole menstrual cycle is geared towards pregnancy. And nature has designed it such that women are only able to get pregnant in an optimum state of health so that they can remain healthy and they can be able to provide enough nutrition for their offspring. So there are certain things that nature has made it that women have to fulfill for their menstrual cycles to work normally and be able to maintain that function. One is health. So if women have any major chronic illnesses, that can impact on their menstrual cycles and stop them either ovulating or being able to conceive. Another is body weight. So at the extremes of body weight, we can find that the menstrual cycle gets disrupted. Okay. So if we take the example that you have given now of an athlete that trains excessively, and it hasn't really it's got nothing to do with weight. Any athlete that trains excessively, whether it's with running, any type of physical exertion, if it is excessive, and if that leads to a significant loss in the athlete's weight, then that can impact on her menstrual cycle. And so when we recommend a BMI range for women who are trying to get pregnant, we recommend that they try and maintain their body mass indices between 20 and 30. If a woman's body mass index falls below 19, then that can start to impact on the function of the menstrual cycle. It can stop her ovulating and it can stop her having periods. So that is actually a functional change in the menstrual cycle. It doesn't mean that the woman has gone through menopause because she still got all the eggs she has in her ovaries, but it just means that those eggs are not developing and she's not ovulating them because the body feels that her body is not in an optimum condition to get pregnant and to nurture a pregnancy and a baby. Does that answer the question, Charles?
Well, I'm sure if she wants further clarification, she will come back. There is a question about, a 27-year-old lady who for the last 10 years haven't had her menses. What could that potentially mean?
That's a good question. There could be a wide range of reasons why that can happen. The first thing I will say is that in somebody that young, the commonest reason why she will not have a period will probably be because of a functional disorder we call polycystic ovary syndrome, where there is just a mismatch of the hormones that are produced to regulate the menstrual cycle. And because of that, ovulation doesn't take place, the lining of the womb is not developed, and so there's no shedding of the lining of the womb. That's the commonest reason why that can happen. But at the other extreme, unfortunately, some women go through early menopause for various reasons, and that could be another reason. Because of the wide range of things that could be responsible. What I would recommend in situations like that is for that person to seek medical help so that they speak to a specialist. And there are very, very simple tests that we can do, mainly blood tests and a pelvic ultrasound scan, and that will provide the answer for why that has happened. And in the vast majority of cases, there are simple measures we can put in place to try and restore the normal menstrual cycle.
Thanks, Doc. More questions about, fibroids, whether you can get pregnant when they are removed, and why are women always offered hysterectomy for their fibroids?
Okay, those are really good questions. When we treat fibroids, the purpose of treating the fibroids are twofold. One, to treat the symptoms that women come to us with. So any woman who's having heavy periods, painful periods, abdominal swelling where they feel they're disfigured, by removing the fibroids, we get rid of those symptoms. The second reason we treat fibroids is to restore fertility. So as I mentioned, any fibroid that is big enough to distort the cavity of the womb, any fibroid that is big enough to distort the tubes and cause a blockage of the tubes can impact on fertility. And by removing a fibroid like that, we would significantly improve the chances of pregnancy happening and carrying on safely to term. So yes, by removing fibroids, we do restore women's fertility.
And why are Black women, offered that regularly?
Oh, yeah, hysterectomy, you mean? That's a really good question. And unfortunately, that is a question that causes me some concern because the hysterectomy is a treatment of fibroids in certain situations, but those are situations where women have completed their families and they do not have need of their wombs anymore. So what I'll tell any woman here, I need to be politically correct in answering this. What I'll tell any woman here is that if they go to their doctor and they still have a desire for fertility, and the doctor is offering them a hysterectomy for their fibroids, they should decline that offer and find another doctor who can offer them the right treatment in their situation.
Thanks, Doc. There's a question about why is lupus prevalent in the Black community?
That's a really good question. Again, we think that there are genetic reasons why this happens. And if there's a genetic predisposition, then as we said earlier with fibroids, if people live long enough, it's likely that they would encounter that condition. So we think it's all down to genetics.
Okay, Doc. And then there is another question here. GPs are not taking appointments for smear or ultrasounds for assessment to be conducted. And meanwhile, there are women who are worried and in discomfort and pain. What can they do?
That's a really, really good question. And I would say it's exactly the same thing in hospitals at the moment. We're not taking any of those appointments at the moment. And we do recognize that it's a distressing time for women. Every GP practice, just like every hospital, should have somebody at the end of a phone where women can call up and speak about their individual situations and get some reassurance. The only situations where we're able to bring people into hospital to do face-to-face interactions at the present time is for dire emergencies that cannot wait. So unfortunately, this is a situation that women will just have to accept is going to be here for a little while. What I can say to reassure women is that things are going to change from July. The hospitals and GP practices are going to open up again. Those services are going to be offered. But as I said earlier, because of maintaining of social distancing and trying to minimize risk of infection, there's going to be a slow build-up. So people need to be patient. If women have distressing symptoms, if they're getting pain that they cannot cope with, they can't manage in any other way, and they're finding that they cannot get any recourse by contacting their GP practices, then they should go to A&E. There is always room to manage such acute emergencies. But beyond that, I would just ask that people are patient. This is not a situation that we can bring back to normality in a few days. It's going to take a while for the services to build back up, but hopefully from July, women are going to be able to start contacting their GP practices and hospitals to reinstate their appointments.
Thanks, Doc. We lost a bit of time at the beginning, so I want to plead with people to, give us another 10, 15 minutes, because there are lots of questions in the chat box and privately. So the next one is, does age impact on the fertility of a woman? Like, those who are younger, are they more fertile? Because from the part of Africa I come from, women tend to start having their family in their late 20s or early 30s. And whilst we're talking about age and fertility, there has been a follow-on question from the 27-year-old who hasn't had, her menses for the last 10 years, whether there is any chance she could get pregnant.
Yeah, I'll address that second question first. I think the chance of getting pregnant if you're not getting your period is extremely small. We never say never in medicine. Those of us who've practiced for long enough have learned that things come back to bite you when you say never. But I think the chance of getting pregnant is extremely small. And that's because the fact that you're not getting periods will suggest to us that you're not ovulating and you're not building up the lining of the womb. And those are two crucial things you need to get pregnant. So my advice to that lady is seek help, find out why you're not getting periods, and it's more than likely it's a simple hormonal thing that can be addressed for you. Sorry, the first part of that question, Charles, was about
age and its impact on fertility.
Absolutely, absolutely. Now, female age is the most crucial determinant of fertility. I cannot stress how important that is. It is the most crucial determinant. And that's because of the reason I explained before. Women do not produce any new eggs in life. So once a female is born, all the eggs she'll ever have in her life are already in her body. So our research indicates that at the time a woman is born, she has about 2 million eggs on average, and she starts to deplete all of those eggs through life. So by the time she gets to the age where her period starts, what we call the menarche, that egg pool has decreased to about 500,000. And all through her reproductive life. So when women go through a menstrual cycle, what the body is effectively doing is selecting out a few eggs from that egg pool. Those eggs start to develop. One of those eggs will get ovulated and the rest will die away. And that's what happens month after month after month until all the eggs in the egg pool are depleted. Now, what happens is that some women might select a small number every month, maybe 5, while other women might select a much higher number every month, maybe 30 or even 40 or even 50. And all of those eggs will get depleted at the end of that menstrual cycle. Now, some women will have short menstrual cycles of maybe about 21 days, while other women will have longer menstrual cycles of maybe about 35 days. So you can imagine that if somebody is having a longer menstrual cycle of about 35 days and recruiting a very small number of her eggs, maybe 5 every cycle, she's going to carry on with her menstrual cycles for a long time. And it's going to take her a much longer time to get to the menopause, compared to maybe somebody else who might be recruiting a much higher number, say about 40, and have her menstrual cycles every 21 days. She's going to rapidly go through her egg pool. And that is why women will get to menopause at different stages. But the key for age is we reckon that women's fertility declines very, very significantly about 10 years before they get to the menopause, because that is the point where we feel their egg pool falls beyond a point where it stops sustaining normal fertility. So yes, age is really, really important, but it's only as important as its impact on the egg pool of a woman. And that brings me back to the advice I gave earlier, that I think once a woman is past the age of 25, she should avail herself of that test called the anti-Mullerian hormone test, and that will give an indication of her egg pool. And based on that, she can make informed decisions about her fertility.
Thanks, Doc. Whilst you're on that, can high FSH and low AMH be reversed? So if you can, I'm sure it's from a medical person, if you can explain what that is, and then you answer the question, please.
Yeah, unfortunately, those cannot be reversed. So the way to think of the AMH and the FSH is the way you think about age. So if you want to think about that question, it's like asking, can age be reversed? Because the FSH and the AMH reflect ovarian aging, and those are not things that can be reversed, unfortunately. And that's simply because women do not form any new eggs in life.
So, Doc, what is FSH for us, the lay people?
Okay, I'll explain the two hormones. So, anti-Mullerian hormone is a hormone that is actually produced by the eggs in a woman's ovaries. So that's why it's such a reliable hormone for us to gauge the number of eggs women have in their ovaries. So your cohort of eggs in your ovaries produces anti-Mullerian hormone. So if we measure that, we can extrapolate that to your ovarian egg pool. FSH is a hormone that's produced by the brain to stimulate the eggs the woman has in her ovaries. So if you have enough eggs in your ovaries, and the eggs are good quality eggs, your brain only needs to produce a small amount of FSH to stimulate them. But if you have a smaller egg pool and the quality of those eggs is not so great, then the brain has to produce a lot more FSH to get those eggs doing what the brain wants them to do. So the way to think about it is that as your ovarian pool gets smaller and more resistant to stimulation, your brain has to produce a lot more FSH to get the eggs to do what the brain wants them to do, meaning to develop and to be ovulated. So as your FSH rises, it indicates that your fertility is diminishing. Whilst because your AMH represents your egg pool directly, as your egg pool diminishes, your AMH will diminish in line with it.
Right, Doc. So earlier on, you talked about the cycle. So there's a question. So if I'm having my menses every 21 days, does that mean that my eggs are getting lower or finishing? What can I do to preserve my eggs, after the 21-day cycle? And there's another question about whether you recommend younger Black women freeze their eggs.
I think those are really, really good questions. The 21-day cycle, it doesn't mean that you're depleting your egg pool much faster. It depends on how many you're recruiting. So ultimately, it still comes down to understanding what your egg pool is, and that will help you to guide what you should think about doing. It comes down to age. If you are a 24, 25-year-old with a 21-day cycle, it's less relevant than if you are a 37, 38-year-old with a 21-day cycle. So it's got to be taken in perspective. And unfortunately, there's nothing you can do to preserve your egg pool as such. There are things that you can do to help. So for instance, for women who are not at the stage where they're thinking of starting a family, if their circumstances warrant going on the combined pill that stops them from ovulating, that can help them to preserve their egg pool, because it means that they won't be recruiting as many eggs in every cycle as they would otherwise. So little things like that can help at that stage in life. Now, egg freezing. I think this is a really, really important thing for women to consider. With a proviso, unfortunately, egg freezing in this context, we call it social egg freezing, is not funded by the NHS. So any woman who's thinking about social egg freezing will have to consider funding it herself, and funding for a cycle of social egg freezing will be looking at somewhere in the range of about £4,000 for that. But for any woman who's not at a stage where they're thinking of starting a family, and because of whatever reason, and they want to give themselves some sort of insurance, fertility insurance, if you like, for later on, egg freezing is a really, really important option that they should consider. I don't know if people were aware about the controversy a few years ago, where Google offered all of their female staff the option to freeze their eggs. So what Google effectively did was to offer all females who worked for them the option to pay for egg freezing, so that women do not have to worry about starting fertility. They could just carry on with their careers without that distraction. And the offer was taken up by thousands of women within Google. So it's something that's here to stay. The technique for egg freezing now is so reliable. When we freeze eggs now, we're pretty confident that about 95% of them will survive the egg freezing process. So it's a really, really effective technique. And because of that, it's a very reliable option for women to consider. I think egg freezing, especially with the Afro-Caribbean community, is something that people should consider. If they're able to afford it, my view is that every woman above the age of 25 who's not at a point where they're considering starting a family should give it some consideration.
Thanks, Doc. Some more questions about menstrual cycle. There's a question about how do you cure or how do you treat or, avoid menstrual pain? It's kept my daughter out of school a couple of times. I know many women who can't go to work. So is there a cure, or how do you manage, or prevent that? And then there's a follow-on question about whether as you age, you're more likely to have less number of days for your menses.
Yeah, I'll take the second question really quickly. The menstrual cycle changes with age. So there is no pattern to how it changes, but we know that menstrual cycle changes with age. So I don't want women to get particularly concerned if they notice a change in their menstrual cycles as they age. That is expected. As long as your menstrual cycles are regular and manageable within your context, then I think that's reassuring. But the length can change with age. Now, when we come to period pains, period pains can be perfectly normal in certain situations. So some women will have painful periods no matter what you do. And in such situations, we will just recommend that they find ways to manage the pain as they go along. And there are measures people can put in place to try and help them manage period pains if that's the case. So using things like anti-inflammatory drugs, like the non-steroidal, things like ibuprofen, and combining that with things like paracetamol, taking about 3 times a day. Things like ibuprofen can be taken about 3 times a day during periods. Paracetamol can be taken about 4 times a day. Those are things that can help women to manage menstrual pains. But I'll come back to the point I made earlier. It is not normal for menstrual pains to stop people from fulfilling their normal functions. So if menstrual pains stop you from going to work, going to school, missing out on your social interactions, that's not normal. And I would always recommend that women who find themselves in that situation should seek help, because there is a reasonable chance that they have something else going on, things like endometriosis, which, as I said, affects about 1 in 10 women. And the good thing about seeking help early in situations like that is if we pick things up like that at an early stage, it is a lot easier to deal with them and get people back to functioning normally.
So I think earlier on when you were talking about when people are offered hysterectomy, someone is shared. So she's saying I was offered fibroid embolization and also a hysterectomy and told to go away and think about what works best for me. I went back and chose embolization and it has worked for me. So women need to ask about their options. So thanks for mentioning that earlier on, Doc. I think follow-on question, but also we're wondering if next week you can come back because it looks like the topic is really important and there have been some requests to spend a bit more time on menopause. So I'm wondering whether next week you can come back. I know you need to check your diary.
I'll check my diary, but I'll be happy to come back because I know these are really important issues. Yeah. So I'll check my diary and I'll let you know.
All right. Okay. So when the period days are reduced from 6 to 4, does that mean I'm running out of eggs?
Not at all. Not at all. Has no bearing. Now there are ranges. There are ranges of normality in all of these. So I'll just let women know that with period days, anybody whose menstrual periods are lasting between 2 and 7 days, we consider that as normal. So as long as you're within that range, we will consider that as normal. And for your menstrual cycles, anybody whose menstrual cycles are ranging between 21 days and 35 days, and as long as there's no more than a 7-day variation between individual months, again, we will consider that as a normal pattern.
Okay, thanks, Doc. Follow-on question from the egg freezing. Is the quality of egg checked prior to freezing, or is it possible that you can freeze the egg and later find out they are of low quality?
That's a really good question. We don't have any robust way of checking the quality of eggs. We have what we call surrogate markers that give us an indication of the quality of eggs. And the anti-Mullerian hormone test, the FSH test, and the ultrasound scan we do, looking at what we call the antral follicle count. All of those give us surrogate markers about the likely quality of the eggs. And ultimately, the process we go through to freeze eggs means that we have to put women on IVF medication to stimulate the eggs to grow. And the pattern of growth of those eggs, again, will give us an indication of their quality. But we don't have any directly robust ways of checking the egg itself.
Okay, Doc. The NHS only supports the IVF cycle until a woman has a baby. How would you recommend the woman rest before starting a new cycle, considering that time is not always on the side of, women?
From that question, what I'm taking from that question is that she's wanting to find out what interval she gives before starting another cycle of IVF treatment.
Yes.
Our advice at the moment is that there is no robust evidence to suggest that any specific interval is more beneficial to the other. So a woman can stop an IVF cycle this month because it was unsuccessful. If they feel physically and psychologically ready to recommence another one, they can start with the very next cycle. There is no evidence that waiting 1 month, 3 months, 6 months, 12 months has any impact at all on your chances of success. So again, if the concern is that by waiting, you're impacting your ovarian reserve and your fertility is declining, there is no reason to wait. If a woman feels ready to, they can start their next IVF cycle the very next month.
Thanks, Doc. What causes women to pass blood clots during menstrual cycle? And can that cause fibroids or affect their estrogen levels? And why why are young girls offered to go on the pill when they are suffering heavy and painful periods?
Okay. Now, the question about blood clots is actually the reverse. Blood clots are actually a consequence of heavy periods. So nature has designed it. Nature has designed it such that periods should not necessarily clot. So any woman who's passing blood clots will indicate that she's passing more blood than she should be. And women will pass more blood than they should be if maybe they have things like fibroids. So any woman with fibroids who has heavy periods can pass clots. So it's actually a consequence of fibroids, not that the clots themselves will cause fibroids or other conditions. So any woman who's passing clots, that will indicate that her periods are heavy. And if you have a heavy period, then as I advised earlier, it's good to find out why you're having heavy periods and if something can be done about it, especially if the heavy periods are causing you a bother. And the question about the pill, it was asking why girls are placed on pills when they have heavy periods and they're passing clots.
Yeah.
The pills are actually a good way to reduce menstrual flow because the way the pills work is that they can reduce some of the causes of heavy periods. So we use the pill to regularize menstrual cycles, especially if women are having what we call irregular cycles with heavy periods associated with them. The pill can be a very good way to regularize their cycles and reduce their menstrual flow and hopefully control the passage of excessive blood and clots.
Thanks, Doc. A few more questions and then we wrap up. Women in their 50s who get pregnant naturally, are their eggs still healthy at that age?
That's a really good question. I think the way to think about it is as women get older and as the egg pool in their ovaries reduce, the proportion of abnormal eggs increase, okay? So if you take somebody, these are just arbitrary figures, so please don't take the figures in isolation. So if you take a woman at the age of 25, it could be that the proportion of healthy eggs in her ovaries will be something like 85%. If you take the same woman at 35, it could be that the proportion of healthy eggs in her ovaries will be 65%. Whilst if you take the woman at the age of 45, it could be that the proportion of healthy eggs in her ovaries is only 25%. What we say is that although the proportion of unhealthy eggs increase with age, there is always a proportion of eggs that are healthy. And if a woman is able to get pregnant, the chances are that it's more than likely she's ovulated one of those healthy eggs that will lead to the pregnancy. However, because of the increase in proportion of abnormal eggs as women age, that impacts on their chances of getting pregnant as they get older. And that also increases the risk of things like miscarriages and the risk of genetically abnormal pregnancies.
Thanks, Doc. Two more questions, and then definitely we would wait to hear from you about another session. And also we've had a comment about getting more men involved, although it's a women's topic, because that will help reduce the stigma.
Can I just comment on that? I think it's extremely important to get men involved. I really do, especially within the Afro-Caribbean community, because men think that this is a woman issue. It's not. We know that men contribute to 50% of all problems to do with fertility. And I think it's really important for them to be involved in things like this to get that information and to know that they have a real role to play within this subject. So women who are around, please drag your men along, kicking and screaming. Anything you can do to bring them in, I think will be really helpful.
Thanks, Doc. So when you come back, you can share some of the issues that men face, right from low sperm count and others. But, two more, and then we will hopefully have you back next. What is the impact of fortnight heavy period on a woman's health? And another question, my daughter started menstruating from the age of about 11 and a half, but then the menses will come for a month, and then there's a 2 months break, and then it will come again. Do I need to be concerned?
Okay. Those two questions are related, actually. So the woman who's having her periods every fortnight, by that I take it that she's having periods every couple of weeks. That will suggest an irregular cycle. So if you're having your period that frequently, then you're losing more blood than you should be losing. So over time, you're more likely to end up with a diminished blood count, become anemic. The fact that you're having your periods irregularly will suggest that there's something underlying that. So my recommendation would be that you seek advice. And as I said, you can have just simple blood tests and scans to find out exactly why your periods are that irregular. And I'm sure there will be very, very simple measures that can be put in place to help you to regularize your cycle. And it's not dissimilar for the man who's talking about the teenage daughter that started her periods early and her periods are irregular. We know that periods can be quite irregular at the extremes of menstrual life. So when we say extremes of menstrual life, we're meaning when girls start having periods, the menarche, and again, close to the menopause. And the reason periods are irregular at those times is because most of the cycles you have around those times are what we call anovulatory cycles, where women are not ovulating. And because they are not ovulating, they're not building up the lining of the womb regularly. And so they can shed and have periods irregularly. On its own, for the young lady who's having irregular cycles, we expect that to happen for a few years and then the periods will regularize. So my advice is if the irregular cycles are not a cause for concern, if they're not disturbing your daughter, if they're not stopping her from going to school or carrying on her normal activities, and she has no other symptoms of concern, it's not a problem. You can just wait. And the expectation is that eventually her periods will regularize as her ovaries go into a normal pattern and she starts to ovulate regularly. But if you're concerned about it, there are things that can be done to help to regularize the cycle. Again, seek medical help, and I think that can be sorted for her very easily.
Many thanks, Doc. We're very keen to have you back. Lots of positive feedback, both privately and in the chat box. But in wrapping up, we know that vitamin D is lower in Black people, for many years now. Why are Black people not offered a blood test to check their vitamin D level? And if, so why are they not given a loading dose of vitamin D by their GP? And this person is asking the question because over the counter, you can't get higher doses.
That's a good question, but I always counter and I always say, it's not everything your GP can do for you. And I think there's some issues that we as a community need to be proactive. So anybody who's listening to this forum now knows that as a Black person, we're more likely to be deficient in vitamin D because of our darker skin tone and the fact that the little bits of sunlight we have here in the UK are not able to penetrate our skin to give us vitamin D. So we should help ourselves. I mean, you can get vitamin D supplements in your local supermarket. Every Black person should be aiming to be on vitamin D supplements. And that would be my answer. And if you're concerned, go to your GP and request to have the blood test done. And to be honest, until COVID arrived, these are not issues that were considered public health problems. So nobody had thought that. We knew that there was a perceived, we knew that there was a slight increase in the risk of Black people having less vitamin D because of difficulty with sunlight penetrating our skin, but that had not been related to any increase in disease patterns within the Black community until COVID arrived. Now that it's been highlighted, I'm sure that public health measures will be put in place to try and address that. But I think as a community, we need to be proactive. We need to take ownership of some of these issues that are peculiar to us, and go to your GP, insist you want the test, and get the test done. But even without the test, every Black person should be aiming to be on vitamin D supplements. That's my advice.
Dr. Edi, thanks very much. I will be following up to check your availability for next week because it looks like there are many more questions, and I'm sure all the audience will be inviting many more people. So I will be following up to check your availability for next week. Any final words?
No, just to say I appreciate being here. So I will try to do my very best to come back, because I know that these are all issues that are really important to us. And I think the more we can get information out there, empower our people, the more we're able to improve healthcare within our community. So I'll get back to you as soon as.
Right. Okay. Thanks, Doc. But then, whilst just before you go, another one is coming saying, I've had a first surgery to remove fibroids. I'm worried about having another one. Would you suggest embolization?
A good question. The issue with embolization is similar to hysterectomy for fibroids. So any woman who has fibroids and who aspires to retain their fertility function for the future should avoid embolization and hysterectomy. Embolization and hysterectomy are good treatments for fibroids, but in women who have completed their families and who are not looking to get pregnant in future. So anybody for whom fertility is important, the treatment is surgery to remove the fibroids. Please avoid embolization and please avoid hysterectomy.
Thanks, Doc. We're really, really grateful for your time and the enlightenment. And thanks everyone for joining. We nearly half hour over the time, but every single person is stayed on, which tells us the topic is really important. So we will check with you for your availability for next week to continue the subject matter. Thanks everyone, and enjoy the rest of the weekend.
Thanks very much, Charles, and thanks everybody.
Thank you, Doc.
Thank you. Thank you very much.
Thank you all. Bye. Thank you, CAHN.
Thank you, Doctor.
Thank you very much. It was very educative. Bye.
Thank you. Thank you all. Have a great day.
You too.